So if you had to elucidate 3 bullet points, what are the goals of an effective stewardship program? What would those goals be?
Assuring responsible use of antibiotics. To me, that's the biggest goal of a stewardship program.
And I would say that for me, and again, this all goes under the optimal use of antibiotics. But I think the primary thing that we do, the most important thing we do, is that patients that come into our hospital with an infection, we get them on the 5 Ds, as she talked about, or I guess it'd be the 4 Ds because they've already been diagnosed from that standpoint. I think that's the most important thing because we improve patient care. We improve outcomes, we decrease bad. But the flip of that is that we have to stop the unintended consequences as well. But it goes hand in hand with doing that. If you do that, you also stop the bad, or at least decrease the bad, which is toxicity, which is resistance, which is C. diff, which is all of those things.
I got it. So it would seem to me, in my untutored way, that one of the things you want to do is be sure that people get the right antibiotic for the right infection, right? And you don't want them to get not necessarily the wrong antibiotic for the bug, but perhaps you want to get a more targeted antibiotic so that you don't get resistance. Mm-hmm. Is that fair?
Absolutely.
All right. And you want to minimize the development of resistance across the board. All this sounds like everything I needed to know about infectious disease I learned in kindergarten. So why the pushback? Where?
So I think a lot of the pushback is when you're prescribing in the moment. And I've actually had surgeons tell me this.
Why is it always surgeons?
Because they're very cavalier with their use of antibiotics. and so
I'm trying to save you from yourself, but there you go.
No, so I love working with them because they're very evidence-based. But there's you go to surgery and an infection post-op, in most surgeons' mind, is a reflection of, I messed up. Like I did something wrong in the surgery. It's a direct hit on them and partially their ego. And so, it's you either have an infection or you don't. And so the prescribing of antibiotics is often just in case they might have an infection because they're perceived as benign drugs with minimal risk. And that's what they learned. And they learned that decades ago. Now, the risk is much greater than that perceived benefit. And that's what we're trying to change. And so stewardship has to convey that. So when you try to talk to a surgeon or an oncologist, the discussion is not so much convincing them about spectrum and that. I go, every day they're on an antibiotic, your risk of C. diff occurring is this. And actually you have them on 2 antibiotics, 3 antibiotics. The more antibiotics per day, that risk continues to go up, and the development of a multidrug-resistant organism. So now, tell me again, what was the benefit? Because I've described to you now, and we're also negatively affecting your microbiome. And that is a real topic that's resonating with surgeons right now. There's a lot of research going on with the negative impact of antibiotics on the microbiome. So when you talk in those terms, it kind of flips the discussion and it makes them think a little differently, and it works.
And I think we've done a poor job of education on the negative consequence.
Yeah.
We've done a lot with education on use this for this is the spectrum, this, not this, but not as much on the nothing at all because they don't really have an infection, or the really think about the total risk benefit. And we think about risk benefit with everything in medicine, right? But it really pertains a lot to antimicrobial utilization. And I think now that we're stepping it up with providers, the next step again is going to be that outpatient thing. So we all think about how much control we have in the hospital, which we sometimes feel is not enough, or sometimes is too much, depending on which side of the coin we're on. But think about the outpatient scenario where really there's no stewardship.
Okay.
And it's driven by patients. So maybe some physicians prescribe antibiotics just in case, but many patients want antibiotics just in case. Many moms want antibiotics just in case.
I've got a cold, can I please have a Z-Pack? That's
exactly. And you don't know there is an unintended consequence of a Z-Pack. You just think it might make me better and I feel so bad, I'm willing to take the chance even if it's 40%.
Is it easier to use stewardship on new drugs than to reach out and control drugs that are out there already?
Yes, because new drugs cost more.
But I would also say
that makes it easier. We
no,
just
but I mean,
focus more.
Well, but it's easier to get support from institutions to do that.
And I would also say that it's a smaller volume And
Right,
so I
absolutely.
don't, if I try to get everybody on the floor that's on ceftriaxone and look at all, that's a lot. But the 3 people who might be relevant to a new drug is a lot easier to
Also,
do.
isn't it habit, which is to say, I've always used this drug. Just if they're not in the habit of using the new one, the gorillamycin, but you can't have it
Gorillacillin.
unless I say so. Gorillacillin, depends on
It's
what,
apomycin.
apomycin. They haven't used it yet.
Right.
So you're going to control
So
that
you're not
reason.
unraveling old habits.
That's my point.